Good evening, everyone. Welcome back to Census, and welcome, Dr. Ksenia. You are back with us. I'm very happy that you are back with us, and we'll present another topic. And how are you feeling tonight? I know it's always a bit later for you, but I hope you are full of energy and ready to present and, of course, answer some of the questions from our patients.
I'm full of energy, and now is the best time because I have long period of appointments during the day and just finished. Now I'm ready to start to continue our speaking.
Glad to hear this then, of course. And let me just mention, if you haven't been on the previous webinar with Dr. Ksenia, let me just mention that's Dr. Ksenia Khazhylenko. She is the gynecologist, a fertility specialist at IVMED, which is located in Kiev, in Ukraine. And tonight we will talk about recurrent implantation failure once again, because actually we already had a webinar on this topic. But as you know, we are focusing on success stories, and we have another interesting success story to show you. And of course, Dr. Ksenia will simply explain all the details, will walk us through all the protocols and what has been done to achieve pregnancy. And as always, there will be time for your questions. So go ahead, type those in the chat section, and I'm sure you will get some advice, and you will hopefully that will help you to go ahead with some more treatments, options, just give you some ideas possibly as well. So let's go ahead. Okay, we have I think everything is set, so we can go ahead with the presentation. And Dr. Ksenia, are you ready to begin?
Yeah, I'm ready. Thank you for introduction, Carolina, and thank you for inviting me. I think it's my presentation really will be hopefully for our patient, for our participants today. And today I would like to present just one story. Not I have not just one, but it's just one because up to me all patient RIF patient story are very long and very complicated, and my story is the same. And firstly, before I start, I would like to say a couple of words about definition. And I'm sorry. Yeah, here is my presentation. This is a joke, of course, and by this joke, I wanted to invocate one very famous person, just to emphasize that RIF definition is one of the most complicated and most controversial in the reproductive medicine, because there is no consensus between experts, between society, between countries in this definition. What does it mean? What does it mean, recurrent implantation failure? And Sorry, my presentation is disappear. Carolina, I need your help.
Just a second, okay? Something happened, but don't worry. Let me try to pull it up again.
Yeah. So
sorry, here it is.
So, thank you. And there is no consensus between experts, and some of them consider that in recurrent implantation failure, this is some unsuccessful attempt. Some of them, that is 2 or 3 or maybe 4 transfers. What about embryo quality? Does it mean that it's have to be just high-grade morphological quality embryos or just genetically tested embryo? If it's genetically tested, could we keep in mind age of the patient after 40 years if it's genetically tested? So a lot of questions, and much less answer on these questions. So let's move on to the reasons of recurrent implantation failure. And as you can see, there is a lot of different situations which cause implantation failure, and starting from lifespan factory and gamete quality and uterine factors and also thrombophilia, etc., etc., etc. But we need to keep in mind that not all from this factor are really have very high grade of evidence based, and some of them are just plausible, some controversial, and let's continue with my story. It's quite young patient, Olga, and she came to me after some unsuccessful attempts of IVF. And on the time when she came, she was 34 years old, and she never get pregnant, and she had unexplained infertility. Unexplained, what it does mean? It's mean that this couple don't have any problem with ovarian function, with fallopian tube, with uterine anatomy, with spermatogenesis. They have normal coital frequency, and we don't have any reason for infertility. And unexplained infertility, it's all the time, it's unknown prognosis. We can say what to be on the next year, 10 years, will be this couple pregnant or not. So this patient, Olga, with her young age and with her normal ovarian reserve, when she started the treatment, she was 32 years old, so she had good prognosis, and they decided to start IVF. And the first attempt was good enough. She had 12 eggs and 5 good quality blastocysts, and one of them was transferred in the fresh cycle, and she didn't become pregnant. And then she, with her doctor, just decided to move on and just provide frozen embryo transfer and transfer one good quality embryos, and she became pregnant. But she miscarried very early, but it was the reason, it was aneuploidy in protocol of conception, and the reason was understandable. So after this case, she could just move on, but she decided just to get reinsured. She decided to test embryos genetically. Up to me, it was not a good idea. But they provided genetically testing of frozen embryo, and 2 from 3 blastocysts tested for euploid. It's a good result. And then before next transfer, she with her doctor decided to provide hysteroscopy, and it was normal uterine cavity observed, and also in material in biopsy of endometrium, and it was a negative result on endometritis. So they provided next frozen transfer. Before transfer, endometrial injury was done, and one blastocyst, genetically tested blastocyst, was transferred, but she didn't become pregnant again. So next attempt, next transfer. Before transferring, they provided additional testing on thrombophilia. Thrombophilia, it's one of the favorite testing. Up to me, it's not always it's really need this testing, because this patient didn't have any individual or family risk factors. But despite this, she tested, and they found prothrombin 2 heterozygous mutation, and prothrombin 2, it's high risk mutation. So We can see Erica. We find out the reason for IVF failure, and they repeat frozen transfer 1 genetically tested blastocyst, and they add low molecular weight heparin plus aspirin, and she didn't become pregnant again. And this was transfer number 4, and this was the last frozen embryo for first stimulation. So she started second IVF attempt, but before stimulation, your husband done sperm DNA fragmentation test, and you can see that it was normal. And then ovarian stimulation started, and 15x 5 blastocysts were biopsied and frozen, and genetical test show 4 from 5 euploid blastocysts. For this age, it's perfect result. But it also means that no reason for previous failure were found. So before move on, Olga with her doctor decided to provide additional test, and they tested endometrial receptivity windows of implantation, and double Erica again, because implantation window was displaced on 1 day later, progesterone plus 6. It means day after conventional implantation window. And also very often when we take the endometrial biopsy for implantation window, we also could study NK cells level in endometrium, and in this patient it was also higher than normally, and this is also Erica. We know what to do. So on the transfer number 5th, 1 euploid blastocyst was transferred on then progesterone plus 6 for displaced implantation window transfer. And also before transfer, it was immunoglobulin infusion was done, but the result also was negative, unfortunately. So transfer number 6, frozen transfer, was transferred on the same later day. And for immunoglobulin infusion was prednisone was added, and also taking into account thrombophilia, prothrombin 2 mutation. It was low molecular weight heparin plus aspirin was added to therapy, but it was negative result also. So after this attempt, she came to me, and there 2 embryos remain after this transfer. And she came to me to just ask second opinion before making the decision. And I always before analyzing, before making decision in IVF patient, I prefer to summarize like this in the slide. You can see summarize all information what have already done in the patient, just to understand why, what was the reason to do in this way. And let's look. This patient had to transfer without any additional add-ons therapy. And later she had some interventions, some treatments, some options additionally. Sometimes it's difficult to me understand why they did this intervention on treatment. It was hysteroscopy, it was endometrial injury, it was low molecular weight heparin, it was displaced embryo transfer, and also immunological therapy. but no effect anyway. We can see some set of options. There is a lot of intervention in RIF patient, and all this intervention we can share on sometimes. Some of this intervention aim to improve uterine factor, like endometrial stretching or atosiban administration to prevent uterine contraction. Some of these intervention aim to improve embryo quality, its embryological laboratory techniques and manipulation, and some of them we use to try to improve environment and embryo implantation condition. I'm about immunological therapy. And also we can use some intervention in attempt to improve endometrial receptivity, like transfer displaying and some manipulation. Also scratching is the same type of manipulation in attempt to improve endometrial receptivity. So this is just set of intervention, and you can see a lot of intervention. And all the time I say that a lot of intervention means that there is no one effective intervention. So this is our attempt to do something in a RIF patient. And we also know that evidence-based do not support majority of add-ons in RIF patient. I think you know this traffic light from Human Fertility and Embryology Authority. And they propose to share all intervention, diagnostic and therapeutic intervention in RIF patient on these three types according to traffic light, and almost all intervention in RIF patient in the amber and red light, unfortunately. So to choose something from these options, we need to understand very clearly why do we choose this option, and what do we want to do by this option. So in my patient Olga, analyzing her personal data, I would present you this my train of my thoughts. So firstly, Olga had unexplained infertility. It means that she had unknown prognosis. She had good PGT results. So for her young enough age, result of genetic testing of embryos was perfect, really. But idea to provide this testing on frozen embryo was not a good idea, and just this intervention could be the reason for failure of implantation in 2 attempts at least. The next, this patient had pregnancy after second transfer. Could it mean that she have displaced implantation window? It's very difficult to understand to me, but up to me, a result of testing of implantation window can means not that she had displaced window, but it can be because of prolonged window. So up to me, a patient who previously had pregnancy after standard transfer, after conventional transfer, had normal implantation window, but it was my train of my thoughts. And I want to explain what I think before making decision on this patient. Next one, NK cells level. Is it permanent or temporary situation? Sometimes in some patient, high NK level can be just temporary, just in one cycle. It doesn't mean that it's next cycles the level of NK will be the same. But it also means that all procedure for endometrial procedure, like endometrial injury, could increase additionally this level if it's really higher. So it means that all stimulated procedure for endometrium, it's not recommended for this patient. It's for the next attempt. Also, when I provide ultrasound on this patient, I find adenomyosis, and adenomyosis it's the type of problems when using of estradiol in ART cycles. It's strongly not recommended because estradiol can cause progress of adenomyosis, and generally patient with adenomyosis and with endometriosis also need some pre-treatment before providing embryo transfer. And also the same about proturbin mutation. Yes, really it's a high risk mutation, but mutation, it's not a disease. It's a bit different. It's just risk factor, high or low, but it's risk factor. And before prescribing something, we need keep in mind different risk factor for thrombosis. And we know that the risk factor for thrombosis is individual or family history of thrombosis, and also age more than 40 years, and overweight or obesity. Also estradiol treatment, so using estradiol during preparation for transfer can be additional risk of thrombotic events. And also some temporary factors like, for instance, immobilization or something else. So our patient, she was young enough and she has normal body mass index, and she has no family history or individual history of thrombosis. But she used estradiol during endometrium preparation, and it can be just one additional factor for her prothrombin mutation. What does it mean? It means that I want to assess all risk factors because making the decision, and I also want to say a couple of words about adenomyosis. We know that adenomyosis, it's very strong inflammatory environment for the embryos during implantation process. And we know also that adenomyosis increase subendometrial contractility in the patient, especially after transfer, and it also can cause cavity deformation, and it can also cause progesterone resistance. So in my patient, I decided the next first, taking into account adenomyosis. I proposed her to use long preparation by blocking by agonist gonadotropin releasing hormone. And I also proposed her to use atosiban to decrease number of subendometrial contraction, to use this infusion before embryo transfer. And taking into account possibly high NK level, I proposed her to use interlipid infusion before transfer, and I also proposed to use additionally progesterone for luteal phase support, because it's well known that progesterone can decrease NK cells number in patients with high level. I also proposed taking into account prothrombin 2 mutation. I proposed her to avoid any estradiol using and to provide transfer in natural cycle. But it's something it's difficult to provide to connect this recommendation in one patient, because from one side I want to use agonist blockage, differylin using before transfer. From the other side, I want to use natural cycle. So is it not very difficult, but it can be long ago. So I used agonist blockage twice, starting from first middle luteal phase, and then I used second injection 4 weeks after. Then after 6 weeks after last injection of differylin shot, we started to provide monitoring of LH, but home testing. And when this test started slight positive, we done a blood test on LH, and when LH search was registered, then I prescribed additionally vaginal progesterone. I also prescribe intralipid infusion 5 days before embryo transfer, and it was my decision. I proposed to transfer the embryo in conventional day LH plus 6. LH plus 6 means the same like progesterone plus 5. So result, as you can see, was positive, fortunately. But regarding the high level of NK cells, we provided additionally intralipid infusion with positive blood test. But I all the time say about not just on positive result in the program, not just about blood test, but about take-home baby concept, and it means that all this time during the pregnancy, patient can have additional risk, miscarriage or late obstetrical complications. So we need to think about this in the early pregnancy. So we provided also additional testing on NK level, just in blood, not in endometrium, of course. And then, fortunately, she has uncomplicated normal pregnancy, and she gave birth and term, and healthy boy. It's her photo. It's this boy. Now he is 3 years old, and this is one of fresh photo. He's very nice, but it's on the photo just get a bit sad. I think it's because of very heartily loves of this boy, but they both are very nice up to me. So my conclusion from this story, that RIF patient, there are different strategies to what to do and how to study and how to treat this patient. And there are first strategy, just use some set of options and just choose something. But up to me, it's better to choose some option and the option understanding what the patient needs, what is the problem, and what we want to have using one or different option. So this is my conclusion, and this is my success story, and this is my clinic. When I work at IVMED clinic in Kyiv, and this is my favorite city, Kyiv. It's very nice and beautiful anytime. And I finish at time my presentation, and I will be glad answer your question if they have. Carolina, do you hear? Yes.
Yes, I can hear you perfectly. Thank you so much for your presentation for this case. This was not an easy case. And of course, it's always great to see that it's possible. There are success stories after all as well. And of course, as you know, now it's your time to ask your
Yeah,
question.
yeah,
So go
yeah.
ahead, type those in. I know that you probably have lots and lots of questions. So even with details, don't hesitate. This is your time. And Dr. Ksenia is right here for you. And let's have a look. Excuse me. Of course, we do have some questions right here. And let's have a look at the first one. Why did you
Well,
think that
so,
PGTA of frozen embryos was not a good idea for this patient?
I mean, I'm just about PGT on frozen, because before to provide biopsy, we need to refroze these embryos, then provide biopsy, and in the same day to freeze them again. So this is very stressful procedure. This double in one day, double procedure with refreezing, biopsy, freezing. And embryo after this biopsy, this type of biopsy, are usually quite weak on the next transfer. And we know it's evidence-based that next transfer can be unsuccessful just because of this biopsy.
All right. Thank you so much for that question and for your answer. Well, next one, it's actually not a question, but a comment that maybe everyone should see. I had the same issue when it comes to the case you provided, and my cases were not even high. So thank you. And I just wanted to.
Thank you for the comment. Yeah.
So
Yeah.
this is not something that is not, like, I would say, maybe not the most common thing. However,
I think in case sales level, it can be the topic for separately for the
no
one
doubt.
webinar, because it's a very complicated topic, because we know a lot of patients with very high level of NK cells in endometrium and in the blood, but this patient have successful pregnancy and successful IVF attempts, but some of these patients have miscarriage and RIF. So is it just matter in NK cells, or maybe something else? I don't know.
Of course. Let me just show you, okay? Because I will actually receive a follow-up. I had similar
Oh.
situation from the same patient, right? And we did follow all the protocols she told, but for my fourth cycle, then I stopped all medical things, and after 6 months, going completely natural.
Oh my
I
God!
conceived.
This is thank you, thank you. This is really the good example of so yeah. I don't
Exactly.
know what yet. I don't know what are you and where are you from, but it is really the
Oh,
example for my
okay.
gods.
Excuse me. There is also a comment.
Congratulations! Yeah, congratulations.
Okay, yeah, and we have a comment. Unfortunately, the patient wrote that I miscarried in 5 months, 2.5, right? So
2.5 months. But I don't know if I can ask the patient. Yeah, can I ask? Do
sure.
you know chromosomal status of the embryo? So I mean, product of conception, genetic testing was provided or not?
Okay, let's give it a second. Someone is typing. I believe this is our patient typing in.
Yeah.
Okay, it was natural conception and no medical intervention. Can you ask again, Dr. Ksenia? Just to.
I mean, after miscarriage, it was a product of conception. The genetic testing was provided or not?
Oh,
This
okay.
natural conception.
Yeah, it was okay. 2.5 months. It was natural conception. Okay, no medical intervention then.
Yeah, I saw this.
Okay, so no, of course, yeah. So no No genetic,
No.
no genetic tests.
So unfortunately, like in my example, it's very important because NK cells on another immunological parameters, very important to analyze just regarding chromosomal status of embryo. In this case, it was firstly genetic testing of embryo was provided. So when we do something to support pregnancy, we have to know that this embryo are really healthy, because sometimes the reason of miscarriage is absolutely different. We can have high level but normal pregnancy.
Okay, thank you so much for adding all those information, all those details, and just so we know, patient India, and she also wrote, since then I have had more than 10 miscarriage, but back in India they said it's normal, so just keep trying.
Yeah. No, unfortunately, yeah. We know that every next miscarriage increase risk for the next one. So what can I do? What I want to help all the patients with the miscarriage. It's my, yeah.
So the best thing is possibly try to find some other, try to get another consultation, maybe look for some more answers.
To have second opinion firstly. And now we know that due to, if I can say, due to COVID pandemic, some of online consultation became much easier than it was 2 years ago. Or maybe you need some online consultation to hear a second opinion about what to do, because then miscarriage, it's sad enough because it's very, very high risk for the next repeated failure despite on treatment, because every next miscarriage add additional risk. With endometrium, for example, with your age became more and more.
Sure. And definitely, in such case, the patient is writing here that she would like to get a second opinion because she's right now in France. So there's a bit backstory. And I think that, in such case, remember that this is, of course, a webinar where you can ask questions. But I think in this situation, it's best to get some consultation. And I just want to mention that, remember, we are always happy to forward any messages like that. If you'd like to get in touch with IVMED and Dr. Ksenia, I'm sure it's possible.
Yeah,
so
sure. Yeah. Thank you, because I need additional information about all test results to make some advices.
So I will simply, I will keep that, and I will simply send, if you don't mind, I will be able to forward your email address to Dr. Ksenia, and I'm sure they will be happy to help you out as well. Okay. Thank you so much. And of course, I just hope that you will get that chance to get at least a second opinion and see what can be also done. Okay. Okay, thank you. I will be able to, I see the email here. No worries. Okay, and in the meantime, of course, we did receive more questions. So let me go to the next one, okay? So can you see adenomyosis on conventional ultrasound?
Sure. Yeah, because there are a lot of signs of adenomyosis in conventional ultrasound. Conventional ultrasound is the best way to see adenomyosis. And there are different type of adenomyosis diffuse. It was in my picture, Carolina. It was my picture with the case, clinical case. It was one picture with ultrasound signs of adenomyosis.
Okay, can we find this?
Yeah, it was. I can, if I can.
Sure, you can move it. No problem
this is
at all.
typical. Oh, that's one. Yeah, this is a typical signs for focal adenomyosis, diffuse adenomyosis, and in this patient, miscarriage, it's a risk factor for adenomyosis also, and often this patient have diffuse adenomyosis with high uterine wall thickness, and one wall is thicker than another one. but some of them have focal adenomyosis very, very similar to myoma, to fibroids. But they're different. There are some different ultrasound signs, but it's here for conventional ultrasound. Yeah.
And thank you so much, of course, for this question and for showing us once again the photos here. And let me go to the next question.
Yeah.
Oh, here it is. I have a frozen pelvis with hydrosalpinx, so most surgeons in my country don't want to operate on me. I have had to fight frozen embryo transfers. What is your advice?
Yeah, thank you for the for your question. In my case, I didn't explain you all possibly reason of implantation failure. But hydrosalpinx is one of the most reason with high level of evidence that association between hydrosalpinx and implantation failure is strong enough, and recommendation to provide surgery after IVF failure, it's logical up to me. Sometimes I can provide transfer in patient with hydrosalpinx first or even second transfer. Just firstly explaining the possibly problems, and especially if we have enough embryos, not one or two. But if we have good quality embryos, we can try in first or even second attempt, and then to back to hydrosalpinx if this attempt are unsuccessful. But sometimes some patients have pregnancy, successfully pregnancy, even with hydrosalpinx. But I think to IVF failure, it's indication for the surgery.
Thanks again, of course, for yet another question. Okay, short question. How do you use intralipids?
Thank you. Intralipid infusion, it's not my my own way to use. It's recommendation of my German colleague from Germany. It's Bettina Toss. It's professor for the Jena University, and she have the most publication about intralipid using, and her recommendation to use 100 or 200 milligrams, firstly before transfer, 3-5 days before transfer. But then they recommend to repeat this infusion if pregnancy test is positive, to repeat it with positive test, and regarding the history of the patient, sometimes they repeat this infusion every 2 weeks till 10-12 weeks of pregnancy, especially in patient who has miscarriage before. They recommend to continue, but sometimes we use intralipid infusion often enough, but in some patients we use just one before transfer, but sometimes we repeat with positive test, like in my this case today. But after positive test, we can do blood test on NK cells level and if it become normal, we don't provide next infusion.
Thank you so much. And we have the same patient asked another question, so let's have a look. So what to do when having abortion due to antiphospholipid syndrome, right?
Thank you. Antiphospholipid syndrome, it's is one of the main reasons for miscarriage. And treatment of antiphospholipid syndrome, it's not just well known, but also have high quality evidence, and it's very effective. It's known that the patient with antiphospholipid syndrome can have successful pregnancy with take-home baby without treatment, just in not more than 15-20% of these cases. But if we treat them, successful pregnancy we can have in almost 80%. So it means like in healthy women. So the treatment of antiphospholipid syndrome, it's using low molecular weight heparin plus aspirin. We don't use any hormones, prednisone. We don't use immunoglobulin infusion, just conventional and quite effective low molecular weight heparin and aspirin. But I want to stress that antiphospholipid syndrome means quite strict criteria for this syndrome. It's not just one time high level of antiphospholipid antibodies. To have this diagnosis, we need to have high level of antiphospholipid antibodies twice with the break at least 12 weeks between first and the second test. And also it can be positive lupus anticoagulant additionally. So if this criteria plus clinical criteria in obstetrician, it's miscarriages, repeated miscarriage, 2 or more miscarriages, so it means syndrome. But if we don't have clinical criteria or some just weak laboratory criteria, it can be not antiphospholipid syndrome. It's very, very important.
Understood. Thank you so much, Dan, of course, for yet another interesting question.
Yeah.
Okay, and Emily has 2 questions now, so let's have a look at the first one. I have high NK cells. Should I avoid fresh transfer?
Why? Maybe you have some additional reasons. No.
Sorry, let me show you this, right? So I also react badly to estrogen and my TSH rises, so I don't like to use estrogen in frozen embryo transfer. Should I have fully natural cycle?
No, of course, sure. Up to me, natural cycle for transfer is the best idea. Up to my patient, I use this type of preparation in 80% of all transfers. It's a good idea, everything. I just don't use natural cycle just in patient who never had ovulation. It can be quite difficult to induce. So if the patient have natural ovulation, it's always good idea. Don't use estradiol. Don't with thyroid problems. NK cells level in natural cycle, there is no difference in natural and artificial cycles between NK cells level. But I just told about additional progesterone prescription in the after ovulation to decrease this level. But it's not about estradiol. Yeah.
Excellent. Thank you so much indeed for that and for the reassurance.
Yeah,
indeed, I'm sure. Okay. Sorry. I just want you to see, Emily has added something. Let me see. I asked the first question because in the case study, she said to avoid transfer when stims are present.
In stims, you mean in natural cycles?
I think so, yes.
No, I don't know. There is no explanation for this statement. So there is no reason, because in a natural cycle, there is some different explanation, not for NK cells, but sometimes maybe you mean there is French school, Nathalie Ledel school.
Sorry, about the fresh transfer.
About fresh cycle. If you mean fresh cycle, you mean cycle of stimulation? Yeah, right, because usually in stimulated cycle, NK cells level will be generally higher. There is some publication about comparing level of NK cells in endometrium in the blood in patient in fresh. I mean a cycle of stimulation. Okay, because cycle with transfer of frozen embryo in natural cycle, it's frozen transfer in natural cycle, but fresh transfer means that it's stimulated cycle. It's really in this type of cycle to get the embryo. Can you fresh transfer if you have high? I mean that in stimulated cycle, really NK cells level will be higher. Yeah, that's true. It's true, and will be better to avoid and use next natural cycle just for transfer. Yeah, that's right.
Okay, I hope that is clear. Sorry, Emily, but I guess now it should be okay. But of course, if you have anything else, go ahead, type it in. Okay. Okay, and let's have a look at some more questions are here. So let me just go to this question from Natalia. RIF is difficult in younger women. What about 40 plus? We don't have that much time and that many good blastocysts to transfer. Do you recommend to screen routinely for some conditions before we face the problem? Hopefully not, but still, any tests?
Oh, it's a difficult question because RIF it's difficult not just in young women, but at any age. But you're right, maybe that usually mostly young patients have good prognosis. And when, despite on good prognosis, they became RIF patient, it's very sad. But when we are talking about the age, let's look the age, that mostly the problem for chromosomal pathology. Yeah, we are talking about the age taking into account high number of chromosomal pathology in the embryo. If this embryo are genetically tested, it doesn't matter what is the age of the patient. So about the question about some additional tests, you're right. Sometimes when I get one or two embryos in age not just 40 plus, but even in younger patient 30, 35, 38. But if there are small number of oocytes and embryos, and for instance, I get just one healthy embryos, so before transferring this embryo, I sit with my patient and I explain her that we could transfer. It can be normally, and it will be with accordance with the protocol. We can transfer in natural cycle up what we need. But if result will be negative and we won't have any embryos later, so we can be very disappointed, and we can think, why didn't we do some additional tests before this transfer? So sometimes if we have a few embryos, I can discuss with patients some additional examination, right? Maybe not all the time they really need this additional testing, but sometimes it can be really important. For instance, testing for chronic endometritis. If for instance, she had miscarriage before or some complicated pregnancy before, and then we plan transfer just one embryo she has. So it will be better to do something to just to get her insurance, maybe.
That makes sense, of course. Thanks so much, Natalia. Definitely interesting question. Thank you for your advice again.
Yeah, thank you.
And let's have a look, okay? Another question. Are there any signals, symptoms that immune system give apart from failed implantation? How can we confirm that? What tests are used?
Difficult question again. Today is the evening on very interesting, complicated, difficult question.
True.
Yeah. Mostly of patient don't have. Mostly of patient with some immunological reaction on the implantation don't have any signs. any signs. But sometimes I can suspect something when the patient, for instance, have some autoimmune condition, autoimmune thyroid, for instance, or some other general conditions with autoimmune antibodies, not just antiphospholipid, and also other. The second one, some of patients have the compliance on a bit higher temperature, especially in the second phase of the menstrual bleeding, or some patients have a bit higher temperature around embryo transfer. Sometimes I discuss with patients the symptoms after failure of IVF, and they didn't say me when it was, but after, when she has negative result, she said me, after transfer, some days I feel a bit strange and I have some temperature, but I didn't say you because I know that it can be normal because of progesterone influence. Yes, really, sometimes progesterone can increase temperature, body temperature, but sometimes it can be the sign of some immunological problems. Which kind of test? It's very difficult because all immunological testing and all immunological treatment are strongly don't recommended by majority of society of reproductive medicine. And this is about this question mostly about your healthy system and organization in your country, and it can be sometimes in some situation some patient have immunological test in context on clinical trials. So ACRM, ESHRE don't recommend to provide any immunological test and in patient with miscarriage or RIF patient. I think it's very generally, and sometimes we really need additional immunological testing. But what to test? It's the question what to test and how to test and when to test. So it's there are general rules. Firstly, the blood and the endometrium, it's a different tissue, different from also immunological point of view. They have different immunological status, endometrium and blood. Also, we don't need any information about your immunological system in the for instance, in the start of menstrual period. We need just information about period of implantation. So if we test, we have test around of implantation window. So it means middle luteal phase. The next rule, the best way to study blood plus endometrium. But you need special laboratory to test. It's not all laboratory ready to provide something, because some of immunological testing, not just NK cells level is more often it's a good test, but number of NK cells, it's not all about immunity, because NK cells level can be higher, but activity of the cells can be lower than normally. And general result, it's normal, and it's not influence for the implantation. But sometimes level can be normal, but activity can be very high. So there are also different part of immunological testing. It's very long area, a very wide area, and I can answer very long time, because it's one.
You could do another webinar on this, I'm sure.
Yeah,
it would take a while.
Favorite topics, but it's all not evidence based.
Oh yes, okay. Still something that is
Sorry.
on trials, etc. It's still something that we need to look more into. Okay. Still, thank you so much. Definitely an interesting question. We could have a long discussion, I'm sure, but thank you for that. And now let's have a look at this question, short one. What about age? Is 50 years too old to get treatment?
If you mean reproductive age and reproductive treatment, it's very also difficult question, because this age, it depends on which country do you live, because in different countries there is different regulation for the age level for ART program. And in this age, it's exactly not about your own oocytes. It's just about donor oocytes. But in different countries, we have different levels. Somewhere it's 40 years, somewhere it's 40A, somewhere it's 54 even. If I write, I can be wrong, but I think in the United States it's 54 is the highest, one of the highest age for infertility treatment. So in my country is 51 year is the maximum when we can transfer embryo with donor eggs.
Okay, thank you for the clarification. And I believe that might be our final question for tonight. So how can you lower high NK level?
Yes, thank you. This is a different type of treatment, and I one more want stress that it's not about evidence-based and about some very special group of patients, and we use different type of treatment depending on previous history of the patient. Did she have pregnancy before? Did she have miscarriage? And also high NK level in endometrium or in the blood, high or not very higher with normal activity or with higher or normal activity or low activity. So a different situation, but generally it can be now it's the favorite our favorite treatment. It's intralipid infusion. Yeah, that's right. And also sometimes in some situation we can use immunoglobulin infusion, and very rarely we use prednisone. It's not recommended, but sometimes in some situation with very high number of miscarriage or recurrent implantation failure, or in patient with very high NK, not just number but also activity. Sometimes we use prednisone to decrease. So different type of manipulation not recommended. There is some experimental treatment to increase, but usually it's enough to use the and also, yeah, of course, progesterone. It's the easiest treatment, progesterone supporting from second phase of menstrual cycle. So usually it's enough to decrease this level, but very often in one patient, not just in case level, but also another immunological problems which we need to treat.
All right, understood. Thank you so much. Of course, another definitely interesting. All those questions were interesting. So thanks so much for staying with us. And of course, for the questions, even those more difficult ones, we are here to, of course, support you and help you out a bit. Dr. Ksenia, you've been amazing again. Thank you so much. I'm glad that you were able to join us once again. And well, there are some comments for you right here. Thanks so much. Thanks for the webinar.
Thank you. It was very interesting for me. Your question, it's very high level. I so sorry that you have this experience to ask this question. This question, it's even sometimes they are difficult even for the physician, for the doctors. And I'm so pity that you have this experience, and I wish you to win in this, yeah, in this
Exactly.
role.
We want more success stories, right? We want
Yeah,
success
yeah,
stories every time.
yeah.
And of course, there are ways. So, as always, fingers crossed to all of you. We do hope that in the end it will be possible, as you know. And thank you so much again,
Thank
Dr.
you.
Ksenia. I just want to mention that Dr. Ksenia, I hope she will be back. This is her second webinar with us, and I'm glad that we were able
Yeah,
to
I will
hear.
be glad to back. Yeah, thank you so
Glad
much
to
for
hear this then, of
invitation.
course.
Have a nice evening, and I wish you success.
Exactly. With that, let's finish, of course, for tonight. Remember, we will be back tomorrow, so I hope you will be able to join us. But of course, remember, it has been recorded. You will have a chance to watch this. Have a relaxing evening, everyone. And, well, we'll see you back here, I'm sure. Okay. Thank you so much.
Okay.
Bye.
Bye. Bye.